Good evening, everyone. Today I am presenting a short case. 3-year, 8-month-old girl, fourth by birth order, born out of third degree consanguineous marriage, resident of Antopale, hailing from UP, Muslim by religion, brought by father with complaints of abdominal distension since 15 to 20 days, passing hard and loose stools intermittently since 10 days. Child was apparently all right 20 days ago when she started developing abdominal distension, diffuse, insidious in onset, intermittent, usually increased after meals. This is associated with abdominal pain, intermittent in nature, umbilical insight, dull aching, not associated with any aggravating or relieving factors. Since last 10 days, child has been passing hard and loose stool alternatively, foul smelling at times, bulky, not greasy, as per the father. Loose stool are watery in consistency, 2 to 3 episodes per day. Uh, Foul swelling associated with passing 2 to 3 episodes of black colored stool 2 days back. Um, History of cough cold present since 4 to 5 days. History of excessive flatulence present. History of vomiting once every 4 to 5 days since last 20 to 25 days. History of fever 10 to 11 days. 10 to 11 days ago, mild grade, undocumented, not associated with chills, rigor rash, intermittent, relieved after medication. History of decreased activity since 15 to 20 days. History of weight loss and loss of appetite since 1 month. History of skin rash present 20 to 25 days ago. Vesicular, fluid containing rash. Now hypopigmented skin lesions present face, over the skin rash area. History of leg pain present. No history of Cox contact, no history of similar complaints in family, no history of previous admission, no history of decreased urine output, no history of mucus in stool, no history of edema, no history of thyroid disorder or diabetes mellitus, no history of ecchymosis or petechiae. ANC history, uneventful. Birth history, home delivery, full-term normal vaginal delivery. Baby cried immediately after birth. Birth Birth vaccine received, no NICU stay, no neonatal jaundice, immunized, developmentally normal, dietary history, mixed diet. Uh, uh, she has calorie deficit of 743 kilocalorie and protein deficit of 4.5 gram. Family history, no similar complaints in family. Father is of 30 years and 28 years of mother. Siblings are of 14 years, 10 years, 7 years, and patient is of 3 years. Uh,
So 3.5-year-old child with abdominal distension about 20 days back. That's your beginning complaint. So how do you analyze this complaint?
the abdominal distension can be because of gaseous distension or organomegaly or ascites. Uh,
Very good. So those are your three big categories. Anything more? One more? Feces. Very good. Now, how do you separate them out from this history? What is the most important word in that description of the abdominal distension?
diffuse.
Fine. So diffuse would suggest what?
Ascites or gaseous distension
Or
or
feces. Okay. And you, like we've discussed earlier, even organomegaly, like a liver disease,
yes,
can lead to ascites. and then become diffuse.
Yes.
Right? So diffuse doesn't help you much, though, yeah, it does. Other way around, if you got a specific history of upper abdominal distension, it would help you towards organomegaly, right?
Yes.
Okay. What else you have written there? Incident.
Intermittent.
Very good. So intermittent is something which you have to double check. And if it is intermittent, what does it tell you?
It can be gaseous or pieces.
Very good. But it can't be
Ascites or
organomegaly and
organomegaly.
ascites. That intermittent is important and that gives you the clue. So assuming that this is intermittent, we take it as either gaseous or pieces.
Yes.
Now we've always told you history is always thought in action. So suppose now you reached this point that it is either gaseous or pieces, and this is since 20 days, then what is the first thought that should come to your mind?
Any altered.
Yeah, so constipation, as in if this is due to feces, then this is constipation, no? So what should come to your mind? Why suddenly constipation now at 3.5 years? So you must first double check what was the stooling pattern before this, because habitual constipation is so common, right? So you have to cross check what was the stooling pattern before this. What was that?
Sir, the father said it was normal before 1 month, and uh, it uh, मतलब father said कि altered bowel habits since 10 days, not even 1 month.
Your double check. So that
Yes, sir.
means there is a change in bowel habits. So this is important and it was normal a while back, whatever,
Yes,
1 month, 20 days. So that is very important. Now, how do you analyze the abdominal pain?
Uh, the abdominal pain is dull aching and intermittent and periumbilical. So it can be मतलब small intestinal pain.
Very good. So one is small intestine. So abdominal pain, always you start from the anatomy first. So periumbilical, what are the other structures?
Uh, Pancreas,
Very good.
liver, left,
Some part of
yeah,
liver, yes.
uh, mesentery, omentum.
Pain of appendix also starts first at periumbilically.
We'll come to that in a while. First, tell me anatomical structures there, and then we will uh, talk about that appendix pain. So, which are the other anatomical structures there?
Lymph nodal pain, mesentery.
Very good. Lymph node mesentery. So, you said pancreas, small intestine, part of liver, lymph node mesentery. So, this pain could be anything from that. Now, take a diversion. You talked of appendix pain coming from there. So, what are the two types of abdominal pain physiologically? Visceral and somatic. What's the difference? So, what's the difference in the appendicular pain, which is periumbilical, and the appendicular pain, which is right iliac fossa? Is there a difference in those two pains? Have you seen any patient go through these stages? Then you will know what is the difference between the pain. So, visceral pain is dull aching and poorly localized. And somatic pain is sharp and severe, but well localized. So, appendicular pain, which comes in the umbilical area, is the visceral pain because it shares the same embryology of small intestine. And then this is the somatic pain of right iliac fossa. That's why it's sharp, severe, well localized. Right? Okay. So now which structure is this pain likely to be from the five that you mentioned?
Intestinal pain. Sight, periumbilical and dull aching, pointing towards visceral pain.
So last time or the time before that, sir discussed what is dull aching pain. Dull aching means what? What does it convey to you otherwise? One is poorly localized. What else? Can vascular pain be dull aching? So what is dull aching? Pathologically, what is happening?
Mild inflammation.
Or distension or stretch of an organ. So you have a liver enlargement, you get dull aching pain. You have an intestinal distension, you get dull aching. You can get colicky also in intestine. That would depend on what is the pathology, whether there's obstruction, etc., etc. Right? So again, the intermittent gives you an important clue. So you should be very clear in your history that this is again intermittent, right? Then it might be that this is intestine again. So first distension you said is intestine. This pain also seems to be intestine, right?
I think in the next slide, you are talking that he was not all right for last 1 month. So the story starts with that. Okay, that is not a past history. That is a present history. So something that started even much earlier than what you are describing. And I think if you look at that carefully, then what does that convey to you? Just put the next slide. Vomiting once every 4 or 5 days for last 20 to 25 days. That means the vomiting was even before abdominal distension. Now we need to ask all these minute details, but looks like there is something. Fever 10, 11 days ago. That means prior to vomiting. See the way we don't get a clear script of the disease. We are getting confused on what started off, etc. Because there is some fever, at mild grade, undocumented, and some intermittent relief of decreased activity, weight loss since 1 month. So we don't know how the story started really. It's getting a little mixed up. Okay. I mean, just take a note of it. What parents must have told you is what bothered them to come to the hospital. But the story started long back, isn't it? And therefore, what do you make out of this? And then we will go back to the previous slide because there is some blood coming out. What does this slide suggest to you?
History of weight loss and loss of appetite since 1 month mm, uh, suggests uh, the mild inflammation or infection going on since 1 month and
Very good. So between infection and inflammation, what you are sure is inflammation, whether it is chronic infection or non-infective, we don't know. Okay. But weight loss and loss of appetite are constitutional symptoms suggesting chronic inflammation. Okay. What else?
uh, a skin rash.
Skin rash. So what does that skin rash look like from this description?
Uh, Vesicular.
Yeah. So what does it? You think it's chicken pox or no?
It can be, according to the history.
So suppose you have to diagnose chicken pox on history only, even without seeing the patient. Can you add some description to this vesicular skin rash? And it will almost confirm that this is likely to be chickenpox. So what else can you ask in the history? Redness around, they are not doctors. So vesicular
Scar-
lesion on erythematous basis for the doctor to pick up.
Scar or scab formation.
Very
of the-
good. So how will you ask in layman's language?
The rash would be in different stages. Like some will be with fluid and some crust and itchy.
Simple words, the layman will say that there are water-filled boils coming up. Old ones are drying and new ones are keep coming up. That is the simple description of this in different stages. And which part of the body?
Trunk. First trunk and
All over the body, but more on the trunk. Okay,
Oh.
but all over the body. Increasing over how many days? 1 hour or 2, 3 days or 1 week, 10 days? So chickenpox increases very fast and rapidly. So first day like 5 boils, next day 50, next day 500. This is the way typical chickenpox goes. So all these things will add to deciding whether this was chickenpox or no. Okay. Then that fever was very undocumented and very non-specific.
yes.
Sir asked you about that vomiting. So what do you make out of that vomiting? What do you make out of vomiting once every 4, 5 days for last 20, 25 days? Think carefully and answer. There's a lot of depth in this whole sentence. What can it be? There are so many things that it can't be. That is obvious from this sentence.
And intermittent obstruction.
Acute intestinal obstruction because that he's having vomiting.
If this was an obstruction, it could not have been once in 4 or 5 days. It could have been in 4 or 5 days interval, but on a one day, several times thereafter settling. So this only means that upper GI is also involved. Upper GI may be stomach or duodenum, and you have an evidence of intestine involved. So this suggests to me that the disease is almost at multiple sites in the upper and lower intestinal tract. Upper intestine would be duodenum, may not be stomach, and therefore you have duodenum up to intestine that rules out infection, and therefore this is a non-infective inflammation. Okay, how you got upper and lower GI? Okay, and then if you look at the vesicular rash, as was discussed, this did not look like simply varicella. On the face of it, yes, but its sequence of events tells us that this is not varicella, but is fluid filled. Then which other rashes are fluid filled is the next question. Some thoughts?
Herpes zoster.
Herpes, which is related to varicella. You are clever. You are giving me a second cause. You are right. Give me something more.
Staphylococcal scarlet syndrome.
Have you heard of Steven Johnson syndrome? Okay. What is Steven Johnson? Immunological allergic response. So this looks like not varicella, but immune mediated response to something. You got so much out of this. You got anatomy, duodenum, small intestine, long. Okay. You got pathology inflammation. You got etiology non-infective inflammation. Now the question is, non-infective inflammation, is it obviously reactive inflammation? It's not immune deficiency, but reactive could also be immune dysregulation, which means malignancy. So now we are left with autoimmune disorder or infection-induced immune disorder or a malignancy. Now go back and say, what was that blood coming? And where do we fit in all this? Black colored stools. Where is it coming from? Fine. So somewhere in the upper part, and our anatomy did say upper part. Okay, not from colon, from intestine. So why is he bleeding? Do you think it's leukemia?
Yes. Because of the inflammation, inflammatory bowel.
So there is almost ulceration. Okay, that bleeding. What's the diagnosis?
Inflammatory bowel disease.
So simple, no? If you really analyze thought-provoking way, you will almost get it. Okay. Now we may not be right. Further, we need to see examination findings, everything. But as we have always said that history gives you 80-85% diagnosis. Okay. And what will be additional by examination? Nothing. He will say he's looking sick or not sick, chronically sick. He's got a certain abdominal distension, there may be mild tenderness, there is no much liver spleen. Fine. So it will not add to my analysis of history. And then the investigation. Investigations, routine investigation, laboratory investigation will not tell us anything. Well, then will leukocytosis, there will be thrombocytosis, but it will not give me a diagnosis. So finally, you'll have to do an endoscopy. But here we could get almost without anything, right? I think that's the fun of thing. So this is the good. He started saying that this is a good story. See, every part of your story is telling us something, right?
Okay, now two questions here. One is, you always have a closed DD in this situation of tuberculosis. So what are the points that have differentiated that is second or lower down on the list?
No chronic fever history.
That, see, you said loss of weight, loss of appetite is constitutional symptoms. You write chronic kind of TBs, for example, TB intestine. You may not get fever. You may have such chronic inflammation, so you will not get prominent fever. So that is
Upper GI.
very good. So anatomy is important. So you said black stool, you took it to upper GI bleed. So upper GI bleed in TB or upper GI bleed telling you anatomy, right? And the second, which sir explained about vomiting. So what would have been vomiting in TB? Vomiting 4-5 times a day for 1 or 2 days, then a gap, and then again such a similar episode. That is your, and that vomiting associated with distension, increased pain. That is your history of subacute intestinal obstruction. Means obstruction for a short time, then which you have to dig in the history, and patient also have to give correctly, then you can differentiate, right? Now, last alternate hard stool and loose stool. This is classical of TB, no? So first tell me what all does this, we discussed that alternating diarrhea and constipation in TB. What does this mean? So 1 minute. You say passing hard and loose stool alternately. Does it actually mean one stool hard, then loose? Does it mean that? Very good. It doesn't mean that. So though we use the word alternately,
Hard or normal consistency stool for.
correct. So now my first question to you, with a history seeming to have loose stools, but he actually has constipation. Is it possible?
Constipation.
Mm. Sir, in constipation, there is seeping of the stool, that liquidy part along the wall of the intestine, then it comes down as incontinence. That is possible in constipation.
Absolutely. So therefore, this is very much possible that a constipated child can give you history seeming to have loose stools with almost incontinence. That is called encopresis also. So that doesn't mean he is not constipated. So one is this could just be that story. So again, what you said, 2 3 days hard stool and then 2 3 days loose stool. You also need to double check whether it is just those loose stools trickling out, but basically constipation, right? What else? What do you make out of this 2 3 days hard and 2 3 days loose?
Small intestine, like bulky stools, but uh, frequency will be less. In large intestine case, the frequency will be more.
Yeah, digestive problem. So digestion is in the small intestine. So if there is a pathology in the small intestine, you will get loose, ill-formed stool, which will suggest that is not getting digested properly. What does hard stool suggest here? That is, this is a acquired problem. It's just for last 1 month.
I think when you have an inflammatory bowel disease, there are several presentations, and based on a typical physiological changes. For example, if there is an irritation of the muscle, okay, you have a mucosal inflammation, the muscle is close by, then the muscle is into spasm, and that's why there is pain. If that lasts for a long time, then you may have a constipation because the stool matter doesn't move further. At the same time, when that is relieved, there is a lot of inflammatory exudate, so you get a loose stool. And therefore, this is not unusual. In fact, occasional child of IBD may present only with constipation. On the other hand, another IBD will present only with loose stools, and some of them will have both, sometimes one or the other. And therefore, this only means that it is something that keeps on changing pathologically or pathogenesis. And sometimes irritation of the muscle contracts, movements are disturbed, and thereafter the muscle relaxes, almost like bronchospasm and relaxation of muscle. Intestine also does the same. Okay, and therefore we might have got an history of a colicky pain as well, but it's difficult because you have dull ache, colicky pain for parents to exactly in a 3-year-old child. So mother's perception of what that pain is not dependable. 3-year-old cannot even point out where the pain is. So that is the problem. The point is, this is not uncommon, but the bleeding suggests that there is a bleeder inside. And what's the bleeder? Almost an ulcer. And therefore, right from duodenum to small intestine, anywhere or multiple areas, you get a diagnosis of straight away a type of IBD that we see in children, not common in adults.
What is this leg pain? What do you make out of that?
It can be the patient has signs of rickets, so it can be uh, the nutritional
Correct.
deficiency.
That is
or-
after examination you have correlated, but 2, 3 questions. Whenever a 3.5-year-old complains of leg pains, what is your commonest? So, what is growing pain?
The pain is more in the night after playing, and it relieves on massaging or analgesics.
So, where is the origin of this pain? Means which structures?
Bony.
Bone, nerve, muscle. This is origin is muscle. So that is why it is relieved on massaging or pressing. And why? What contributes to this? Hyperlaxity of joints. So you need to look for that, right? It may not fit into all those criteria that what that B पे से कौन सा criteria है? Some hyperlaxity criteria from B. I forget the name, but it may not fit into that. But still, uh, you need to look for hyperlaxity. Is rickets painful? So then you said this is due to rickets. So what is it? So does rickets have osteoporosis, osteomalacia? Is adult osteoporosis painful?
Adult osteoporosis after if fracture associated with pathological fracture, then painful.
Even otherwise, adult osteoporosis is painful. So osteoporosis and this rickets is different. In rickets, what happens is uh, your growing end of the bone is osteomalacia, right? Whereas in adult, the osteoporosis is kind of uniform. So that is painful. This is not. So in rickets, you talk of 2 types of rickets, hypocalcemic and hypophosphatemic. So they have a myopathy. So hypocalcemic rickets have a myopathy and they can have leg pains because of the this thing, right? Okay.
In leg pain, you could have asked many questions, both pains, one leg, how severe, mild or not, whether you massage and you feel happy, movements make it difficult, all that. But can I request Tushar to put on the chat the criteria that you are putting up? I'm not aware of that. It will probably make us know something more. So please put on the chat some criteria for leg pain. I'm not aware of it.
So what? Any one or two which
Yeah.
you know.
Yeah.
Yeah. So no. So these Brighton's criteria are you have to do some tests, like you have to flex the thumb across the hand and see how much it is going. Then you have to flex the wrist. So these are all. So when you do this, you're not able to bend it across. But when you bend it across to parallel to your lower end of the forearm, then it's a hyperlaxity. So some such criteria are there, right? You can read up. There are 4 or 5 criteria. Yeah. A score of 4 or more out of 9 is important. So the ability to place palms flat on the floor with knees straight. That means you go down like this and you are able to place your palms on the floor, right? So that way. There are many, there are 4 or 5. Okay, yeah, Tushar, Pallavi ma'am, can you unmute Tushar? Tushar Maniar? Let me try.
Rajesh, you
Yeah,
can hear
Tushar.
me now.
Yeah.
Yeah. So what I remember basically one is hyperextension of the knee joint. So normally when we stand, our knee gets locked in a vertical position, but if it goes in hyperextension, that is one of the criteria. Similarly, hyperextension of the elbow. So when we make the hand straight, the elbow extension instead of remaining straight, it goes further back. Similarly, if you remember from Marfan's, we do that thumb sign. So if you are able to touch the thumb on the volar aspect of the forearm, that is one more criteria. And finally, when you try to touch the floor by forward bending with knees which are kept straight, normally most of us have difficulty in touching, but at the most we'll touch up with our fingertips. But if you are able to keep the palm flat on the floor without bending the knees, that would show hyperlaxity. So these are some of the, I may have missed one or two, but these are some of the criteria for hyperlaxity. And if there are
Perfect.
more than 3 positive, then it is considered as one as Brighton positive.
Perfect, Tushar. Anjali has put up the same. She's put up one more, which is extend dorsiflexion of the little finger so that it goes back right till the end, right? So these are the criteria. Okay. Fine. Now,
I think many normal people also have it. I could see you have it. Yeah, that is not quite, it's not syndromic. It is just an isolated characteristic. I saw you are doing it, and that is pretty common. When I see such a child, I often ask the mother or father, and one of them also has it. Okay, it's quite normal. Yeah.
yeah. Now, you asked for history of ecchymosis petechiae. Why did you ask that?
Sir, um,
Because of the bleeding.
bleeding disorder and also for malabsorption.
Okay. Meaning intestinal disease, so malabsorption. Okay, fine. Okay, fine. Okay, so now come here and you've not, means you should tell us your provisional diagnosis or your summary and then go to examination findings.
Uh, 3 year, 8 month, 3 year, 8 month old girl, born out of third degree consanguineous marriage, came with complaint of abdominal distension and altered bowel habits with uh, um, history of intermittent vomiting and a history of um, vesicular rash and with history of weight loss and loss of appetite. Uh, is- with calorie and protein deficiency is probably a case of in malabsorption syndrome or inflammatory bowel disease.
Okay. So generally, when you are asked to summarize, you should try to give your interpretations and not repeat the the complaints that the patient has come with. Okay. Anyway, chal, go on.
On examination, patient was febrile, pulse rate of 102 per minute, regular, no radio femoral delay, RR of 30 per minute, regular rhythm, saturation 99% on room air, peripheral pulses well felt, extremities warm, pallor present, head to toe examination, lustrous hairs, sparse hairs, hyperpigmented macules over face, predominantly over forehead and uh, nose, developed after fever with vesicular rash, fluid filled, hypopigmented macules over forehead, hyperpigmented macules over trunk, dry skin present, frontal bossing and wrist widening present. Anthro-wise, the weight is 12.7 kg, which is between -1 to -2 standard deviation. Height is 98 centimeter, between 0 to -1 deviation. Head circumference 47.5 centimeter, between -1 to -2 deviation. Uh, Mid upper arm circumference 12.6 centimeter, -2 to -3 deviation. Weight for length, -1 to -2 deviation. Impression, moderate acute malnutrition.
Wait, what do you all say to this anthropometry?
Whole idea of analysis is you must tell us when did the story start, what's the duration of illness, and how fast or slow the disease has progressed based on this.
Anthropometry more looks like acutely the child has developed the illness because uh, height is normal, then weight is also not, no acute wasting and all.
Sir, weight is affected more than height. That suggestive of more of acute illness, where height weight is decreased more than height.
Even weight is within -2 to -1, so weight is also not much affected. So there is no malnutrition. UAC.
First of all, let us understand what is this -1, -2 standard deviation. What does it mean? What does all this standard deviation business mean?
It is compared to a normal child of that age and sex, and it, it should fall within +2 or -2 of standard deviation, like what a normal child is having, the deviation according to the formula.
Let's revise this because we need to revise this 50, 60 times before we'll remember it for life. Okay? How many of you are abnormal? Nobody? Are all your weights the same? Are all your heights the same? So if we take all your weights or your heights and plot them, we will get a range. Let's say from 45 kilos to 62 or 68 kilos or whatever. So you'll get 8 or 9 different readings, correct? From 45 to 69. The most central reading will be called the median. And then there'll be some readings on both sides. So the point is that for any parameter, when you take multiple readings, you will get a central reading where many people will fall on that reading. But there'll be lot of people on the above side of that reading, and there'll be a lot of people on the less side of that reading. So it has been decided by convention that 2 standard deviations on either side is normal. That's the definition of normal. So 95% of the readings will fall in this range. That is why it is called normal. Correct? So the first thing we have to keep telling ourselves is that -1 or -2 standard deviation does not mean abnormal. It is still within the normal range. It is just that it is less from the middle reading. That's all. Okay. There's nothing like only middle reading is normal. This is also normal. So that was the first understanding. Now, what is mid upper arm circumference and what does it tell you? Why is it age independent?
From 6 months to 5 years, the mid upper arm circumference remains almost fixed, or because the muscle mass and fat tissue are in fixed proportion, and muscle mass will replace the fat as age advances.
Very good. So it is constant because muscle increases or and fat decreases proportionately. So it is constant. So now if you were to extend your imagination to these readings, technically this child is in a normal range for height and weight. And remember, it is not compulsory that if height is -1 to 0, weight has to be -1 to 0. It is not necessary. Everybody has a different build. So on a growth chart, if my height centile is on the 25th centile, it doesn't mean my weight has to be on the 25th centile. I could be a little higher or a little lower. That would be genetic or so many other factors, right? So technically here it means that only MUAC is gone below or it has gone down, which means that the fat component has suddenly gone down, which might mean a acute weight loss. At one time, that weight reading does not tell you weight loss because you never know the previous reading. So technically, if he was, let's say, 14 and he has become 12.7, he is still within that normal range. So you'll call him normal, but he seems to have lost weight acutely. That could be your interpretation. So, as you rightly said, acute disease, right? But more importantly, don't mix up on that -2 standard deviation.
And I think that MUSL tells us that it's acute, fastly progressive disorder. Okay, that's why the fat is lost. Okay, and therefore we said origin, duration, progress. You are right. Recent, maybe 1 month or whatever. Duration we know, progress rather fastly progressing. That is the thing. So this is not MAM really, right? Yeah.
Systemic examination, per abdo examination, inspection, abdomen normally
Child is not here, no? Okay.
discharge. Abdomen normal in shape, no dilated veins, umbilicus in central in position. Palpation, superficial palpation, soft, doughy abdomen, no tenderness. On deep palpation, liver palpable 1.5 centimeter below right costal margin along mid clavicular line. Soft in consistency, non-tender, spleen not palpable. Percussion, liver span 7.5 centimeter, auscultation, bowel sounds heard. Uh, Rest of the system no, within normal limit.
So, is there any abdominal distension?
Um, on at presentation, sir, no, but there was history of intermittent abdominal
Yeah, but
distension.
when you examine, no.
No, no, sir.
Okay. So, again, this is to be taken a little more carefully and accurately. I mean, I don't question you that there was no abdominal distension. what is the normal abdomen of a 3.5-year-old when this child is lying flat on the bed? Means, is it a little convex? Is it flat or is it concave?
Mild protuberance will be there.
Mild protuberance may be there, but actually when you make the patient, so when they are standing and walking, they may have a protuberant abdomen. But when you make them lie down, it is likely to go under that flat level, but not necessarily scaphoid, right? So those subtle things also you need to observe. So it may not be distension, as in it may not be convex like a semicircle, but you could have some fullness of abdomen which suggests that there is intestinal distension, right? So if patient would have been there, we would have been able to observe.
What is this doughy abdomen mean? We use this term. I'm sure most of you also must not have palpated the dough. I have not. Then how do I know doughy abdomen? So can you describe doughy abdomen?
So,
Your
uh,
mothers would know what is doughy. I hope you also may have occasionally known.
If we press, it won't bounce back. There is indentation.
Firmish, distended, but often can be indented. That is exactly the dough is. It's firm, but you can make some dents on that, right? And generally that means really a abdominal distension as well, right? But it doesn't matter. Those small, we just want you to be aware that you should not be caught up by any statement that you make. That's all, right?
a 3-year, 8-month-old girl born out of third-degree consanguineous marriage with complaint of abdominal distension and altered bowel habits, with history of vesicular skin rash over face and trunk, with history of weight loss, with pallor, with um, calorie protein deficit, with signs of rickets, developmentally normal, immunized till date, most probably a case of inflammatory bowel disease, malabsorption disorder like celiac disease or abdominal TB.
Okay, so come, 1 minute, you come here. Yeah. So why celiac disease?
Because the uh, rash seems like dermatitis herpetiformis and matlab pallor is present, weight loss is present, so malabsorption syndrome.
Okay. So rash you said looked like dermatitis herpetiformis when you
Yes,
saw the rash,
I didn't saw the rash. I
history wise. But when the
physically
child came, you all didn't have a picture or the rash was not
no.
there. Okay. So see, the point is that weight loss and pallor are soft signs, means they are not strong pointers to celiac disease. Pallor, of course, can be anyway common due to deficiency. You'll have to go into the diet to see was the diet good enough in iron. Otherwise, it could just be iron deficiency, right? It looked like a healthy child, and you are saying there were signs of vitamin D deficiency. So there could well be iron deficiency as well. Okay. Again, there's a separate discussion that in a 3.5-year-old child, signs of vitamin D deficiency, are they active or are they old signs? How will you make out? Would a 3.5-year-old have active nutritional rickets? Clinically, we are saying. So typically active nutritional rickets is at a younger age. Not that it is impossible at 3.5, but then there would be lot of deformities, very obvious big deformities. So worsening deformities suggest active disease. Otherwise, it could be that it was old disease, right? So coming back to pallor, it could be deficiency anemia, just nutritional. So that alone does not point to celiac. Okay,
On CBC,
we'll come to investigation. So clinically, I think from this history, I would put even IBD as a possibility, not really celiac. The problem is it's going a little too fast. So that in fact is making us wonder whether it's something more serious that way.
Celiac is also an immune disorder. So you're basically talking about the same pathology, but we started 1 month ago, which also was corroborated by our weight, height, etc. Second is it has progressed very rapidly. And therefore, by and large, malabsorption is a slowly worsening situation, whereas this is acute onset, short duration, fastly progressive, and even some episodes of fever may be undocumented, you said. And therefore, I would put it as an IBD. Today, even an infant can get an IBD. It's not that IBD is a little older child. And therefore, again, a significant blood coming out. Okay. Which means that there is some capillaries which are damaged and opened up. That again suggests a severe inflammation. While both are inflammatory disorders, one presents with a slowly progressive malabsorption, and often will go to an endocrinologist for short stature, may go to a hematologist for untreatable anemia. That's kind of a chronicity. Whereas this is acute onset, short duration, fastly progressive. Therefore, I would rather call it as an IBD and not celiac, because the management is going to be totally different. Now, what happened a month ago that suddenly this child is reacting to wheat or rye or whatever? Unusual. Okay, there is no sudden change in the diet. So, and same is true about abdominal tuberculosis. We are not very seriously thinking about abdominal tuberculosis also, because again, it's a short duration, acute onset, fastly progressive. So I think I will put it as an IBD only.
on CBC, WBC counts of 4,000, HB 6.8, HCT 20.3, MCV 104, MCH 34.8, MCHC 33.3, platelet of 1,41,000.
Okay, wait. What does that tell you?
Megaloblastic anemia. MCV is 104, more than 100, suggestive of anemia, megaloblastic anemia. The PS also done for her, which suggestive of hypersegmented neutrophils, megaloblastic changes, teardrop cells present, large platelets, and macrocytic normochromic hypochromasia.
Okay. So megaloblastic anemia. Then
Um, BUN is 11, creat 0.5, sodium 139, potassium 4.1, chloride 100, total bilirubin 1.6, direct bilirubin 0.6, SGOT 26, SGPD 22, total protein 6.9, albumin 4.8, and USG abdo done for her, which suggests of abdominal lymphadenopathy and minimal interbowel fluid.
lymphadenopathy is significant. They've given the size or something.
Sub-centimetric, sir.
So what do you think? Subcentimetric lymphadenopathy?
Largest 1.4 into 0.6 centimeter.
So at this stage, these lymph nodes are not significant, right? And nothing else is there on USG, right? Oh. Anything more you've done?
Stool RM was done, occult blood present. The total TTG and total IgA was sent for her.
So what TTG report is not?
Not yet come.
Okay. And if you're thinking of IBD, then what would you do?
Scope.
Okay, endoscopy
Bio.
and stool. What does that tell you?
For Crohn's disease, it will be elevated.
It's an inflammatory marker, protectin on stool, but it has its problems in interpretation, especially when there is blood in stool, right? Fine. So presently you just sent TTG and you're waiting.
Yes, sir.
Chest X-ray was done.
Yes, sir. But was not. Picture is not there. Normal. It is normal, sir.
No, why I'm asking is you're saying abdominal tuberculosis, so you have to do a chest X-ray to rule out, na? Matlab
The
to screen.
chest X-ray was normal.
Yeah, good. Fine. So let us know next time whatever comes out of this child's investigations. Yeah. Okay.
Thank you.
Thank you. Who's presenting the second case? Come.
Rajesh, just a question.
Yeah, Anjali.
This child had typical post-inflammatory pigmentation over the nose and face, which is also seen in chikungunya. So, whether chikungunya could be a possible cause with this kind of gastrointestinal presentation? I've not seen any. Just thought if you all have.
Yeah, so the other side of the story was very unusual. It could have been an intercurrent illness, if at all, as in two different things.
Okay.
Probably not the whole thing explained on chikungunya.
Yeah.
You found anything of the rash finally? Matlab, what was the rash? No.
The rash was resolved, sir, but hyperpigmented macules was there over face and neck. No. No. No, sir. Not written.
Fine. They're asking any hyperpigmentation of knuckles were seen in this child? There were. Okay. Also, just one point, Anjali, that chikungunya, that pigmentation is a kind of a diffuse, localized or whatever pigmentation. As in here, she is describing hyperpigmented spots, as in macules. So that also is a small difference.
Yeah, but chikungunya, that nose hyperpigmentation was very peculiar. So most means at least I have seen 2 or 3 chikungunyas with nose hyperpigmentation.
Agreed. I am
Yeah,
saying that on the nose, you'll get a kind of
diffuse, not
area of
yeah. Yes,
hyperpigmentation. She
yes,
is describing discrete lesions. So it
yeah,
is some other eruption which is healing.
yes,
Because she also described hypo. So both hypo and hyper are healing stages of some eruption.
yes.
Yeah, sure.
Okay, thank
Okay.
you.
Okay.
Good evening. I'll be presenting the second case for today's Thursday clinic. 3-year-old female child born out of non-consanguineous marriage, hailing from Assam, Muslim by religion, Khanbai community. brought by and informed by mother came with complaint of cough and cold since 5 days, fever since 5 days, and increased work of breathing since 3 days. It was apparently already 5 days ago when she had complaints of cough, which was mild to moderate, dry, intermittent, non-spasmodic, associated with 2 to 3 episodes of post-tussive vomiting. Cold was in form of nasal discharge, intermittent, watery. Fever was high-grade, intermittent, with resolving on medications, and child was active during the interfebrile period. Increased work of breathing was there in form of increased rate and depth of respiration. For the above complaints, the child was taken some local treatment and nebulization was received at home. Then the child was referred to a hospital in view of worsening respiratory distress, which was not further settling on nebulization. There was a history of bottle feeding. There is no history of oil installation in ear or nose. No history of fever with chills. Fever was there, but there was no history of chills, rash, or rigors. No history of any ear discharge. No history of COX or COX contact. No history of decreased urine output. Then past history and ENC history was not significant and uneventful. In birth history, the child is moderate preterm, 33 weaker. LSES was done in view of oligohydramnios. Birth weight was 2.5 kg. Cried immediately after birth with no history of NICU stay. Developmentally, the child has only isolated gross motor delay. Other milestones were appropriate for the corrected gestational age. Dietary history is mixed family diet, and the child consumes from the same family pot, immunized till date, and no significant family history.
So come, about 5 minutes, come here. So, do you think the exact order of these complaints is important or not important? And how does it change your thinking?
All three complaints fever, cold, cough since 5 days, and increased work of breathing uh, since 3 days.
If all three complaints started on the same day, what does it mean? Come on.
Infections start at the same time with both systems.
Okay.
LRTI.
Some acute event for all the three things to start together.
If they start together, there might be some upper like epiglottitis or croup is sudden onset coming all at a time, preceded by some viral.
You're all getting very mixed up. So basically, whenever you have fever, cough, cold, first of all, be 100% sure that there is a cold or no. Because that cold yes or cold no makes a difference. Okay. Now, viral infections can, you can have a prodrome of cough cold for a day, and then next day you can get high fever, or you can have fever, cough cold almost starting together, which is also a viral infection, or fever but soon followed by cold and cough, which is also a viral infection. But in a bacterial infection, a pneumonia, lobar pneumonia, classical, you will start with fever, high fever, which will go on for a certain length of time, usually 2 3 days, and then the breathlessness will come in. Till that time, there may be hardly any cough. So try to make these distinctions in the timetable to be able to decide whether it's a viral infection or a bacterial infection. You understand? Okay. Now, the assuming that this is cough cold since 5 days, fever since 5 days, that means everything together since 5 days. I would more err on the side of viral rather than bacterial. In which case, why did he become breathless 2 days later? Why would a viral infection become breathless after 2, 3 days? What can happen?
Superadded bacterial infection causing pneumonia.
Okay. Aspiration due to cough. Okay.
Spread to the airways bronchioles, leading to increased work of breathing.
Spread to the airways, as in viral infection is anyway a airway disease. It spreads along the airways. So usually it wouldn't make someone breathless after 3 days. After 3 days, breathless means some complication. So even in a viral infection, it is possible. But I'm asking you, what all can it be? Okay, so it can trigger off a bronchospasm in a reactive airway, in a child who has a reactive airway disease. What else?
Causing any effusion,
Okay.
developing some effusion.
Effusion has to be very big to make the child breathless. And why should a viral infection lead to a very big effusion? So they can get into what is like a ARDS or a interstitial pneumonia ARDS situation, which is again immunologic, which will happen after 3, 4 days, which can happen in any of the strong viruses, H1N1 or whatever.
I think in the next slide you mentioned dry cough. Dry, right? Now, dry cough takes you away from a lower airway. So again, check on that. Parents may have told you dry, but why should a dry cough should mean lower airway? Okay, that is number one. If a dry cough exists in a breathless child, then it's a laryngeal one. Then is there a hoarseness of voice? Now, this is the way you confirm whether it's really dry or not. In a small 3-year-old child, it's not possible for parents to know whether dry or wet because they feel when there is no expectoration, it is dry. No. In fact, the 3-year-old child may not be able to cough and may not be able to get anything out. And then you have said post-acid vomiting, which could also mean that he has the lower airway involvement. It's a wet cough, but he cannot get it out. So he exerts and even has a post-acid vomiting. So these things need to be checked properly. The next thing important is that what has happened to fever? Has fever continued? Has fever getting worse? Or has the fever disappeared? That is most important. If the fever has disappeared and he is having breathlessness, it could be a viral induced reactive airway disease. But if the fever continues or even gets worse, that means the infective illness is progressive. Then the next is, why is it progressive? Now, typically, this is not a situation where you get easily secondary bacterial infection. There has to be a reason for a secondary bacterial infection. While we know secondary bacterial infection can happen, it happens only in specific situations. One is when there is a retention of secretions, like a bronchiectasis, or when there is an immunosuppressive viral illness, like measles. But this did not look either of that. But more important to me is that this 3-year-old child is still bottle feeding, then he cannot be normal child at all. No bottle fed child at 3 years is healthy and normal. Simply because he's bottle addicted, he doesn't eat well, parents force him, he further vomit. So bottle fed at 3 years is unlikely to be an healthy child. And again, we have been harping every time, be sure he was normal, not because parents said that. Has he been growing well? Has he been growing in height? Has he been active and playful? Is he energetic? Does he sleep well? Is he happy, playful? So many things to ask whether this child has been. But bottle fed baby to me is not a normal child at all. Now, all this is considering the normal situation. Somebody who is bottle feeding is also eating well is a different story. But one who is bottle addicted cannot be eating well. So these details need to be seen. If has fever continued in this child? Has the fever got worse in this child? If you don't know, then you say don't know, because then we will get our impression based on that. Point is, if you don't know, then you have learned that next time you will be asking this. That is important. Okay. And I think if it's worsening, then it's a progressive illness. Then you start wondering, could it be a bacterial infection to start with? Now, if that is so, why was there was cold? So again, he made a point. Cold means running nose, blocked nose, or nothing. Cold and cough go together. So now, if you know that there is no cold at all, then could it be a bacterial infection itself? And now he is developing pneumonia, right? But why is he coughing badly? So how bad is the cough? Is the cough severe? Then it's an airway. If the cough is not severe, it may not be airway, it may be a lung itself. So many details can make us diagnose correctly, right? And these are basics. We are not talking about anything unusual discussion. Whenever there's a cough, you ask all these questions. So here we don't know. Surely it looked like a virus, but continuing like this, like he said, have you got into an immune complication like ARDS? But generally the fever would have also gone down, he would have got worse. So we are not very clear what's happening.
On general examination, the child was febrile and sick looking, with a heart rate of around 180 and respiratory rate of 64 per minute, with subcostal and intercostal retractions and nasal flaring present. Saturation was 97% on bubble CPAP. Peripheral pulses were well felt and extremities were warm. CRT less than 3 seconds. Pallor was present and right-sided subcentimetric cervical lymph nodes was present. Upon head-to-toe examination, there was frontal bossing, poor dental hygiene, pigeon-shaped chest was present with wrist widening, rachitic rosary, and protuberant abdomen, bowing of lower limbs, and double malleoli. Upon systemic examination, there was symmetrical chest wall movements, air entry bilaterally decreased, with V's present and bilateral crypts in right middle zone and left middle zone. On CVS, CVS was normal. CNS wise, the child was irritable. Rest all findings were within normal range, and per abdomen was also soft and non-tender. So to summarize, a 3-year-old female child with complaints of fever, cough, and cold with increased work of breathing, with tachypnea, retractions, and on examination with findings suggestive of rickets in a case of bronchopneumonia to rule out further causes of rickets. Anthro-wise, sorry, I forgot to mention, anthro-wise, the child falls under SAM.
What do you think could be the cause of rickets in this child?
Nutritional,
Why?
SAM.
So SAM, actually we say rickets is a disease of growing bones, no? If he's SAM, then why should he have rickets?
Could be hypophosphatemic or vitamin D, vitamin D, VDDR.
All that is, if there's any specific pointer, why should I directly jump to VDDR now in this child? It's theoretically one possibility, but is there any pointer to that? Hmm?
Of bottle feeding, nutritional cause. More looks like nutritional cause.
The child was premature, you said, no? So the very fact that this was premature means he has come out with less reserves. And add to that wrong diet or whatever. So that's quite likely deficiency rickets only. Now, you don't remember the weight and height, so we can't judge the growth of the baby, but mostly it is deficiency rickets. Now, how do you interpret these signs? Is the disease unilateral or bilateral? Is respiratory disease? Bilateral. You got Krebs bilateral and Ronchi bilateral. So how do you interpret that? Where is the anatomy of the disease? Is it a lobe? So do you expect a consolidation of one of the lobes, or what do you expect? It's an airway disease, right? So these signs are suggesting an airway disease. Now, as sir already said, there are a lot of things which tell you, which make a difference, whether it's a infection that is going along the airways. So then you start thinking of atypical organisms. Age is actually 3 years only, but not that it is not possible. So many such factors. And if fever has settled down, then whether it's just a reactive airway disease component of the triggered by the viral. So all these plus minus things are there, right? You have any X-ray or anything? Sure.
Bilateral air entry is decreased. Why? Bilateral air entry is decreased, right? What does that mean? Bilateral pleural effusion? Then
Because of the airway inflammation, air entry.
what is the pathology? So bilateral emphysema. We have not, he has not told us what the percussion is like. Okay. There is a wheeze. Wheeze would mean retention of air. So this is bilateral emphysema. Okay. There is a wheeze. So obviously it's a generalized airway disorder. And now fever is not there. So it's certainly hyperreactive. Okay. But why those localizing signs?
Parenchymal involvement.
What kind of involvement? You are right. But what kind of consolidation? Bacterial infection or a viral pneumonia? What is it? And therefore, these are small areas of atelectasis. You have a bronchospasm, you have an emphysema. Majority of the airways are blocked, retaining air. At some places, it's not completely, he is showing crepitations as well, wheeze as well. So it's not that the air doesn't go in at all, but air doesn't come out well. And therefore, there must have been some small areas of atelectasis because of some mucus plug. That is the combination. And how important it is to see that now we know that fever had disappeared and breathlessness had come in. So that made simply a diagnosis of a hyperreactive airway triggered by a viral infection. See how the science alone will not tell us that. Luckily, we got bilateral emphysema. So we know that it has been a bronchospastic illness, but no fever now. So this was simple hyperreactive airway.
Prashant, you have the mic.
These were the blood investigations. Yeah, on CBC, hemoglobin was 11.4. WBC count was 15,930 and platelet were 4,71,000. Upon all routine investigation, also alkaline phosphatase was markedly elevated, 1792, but serum calcium was decreased 7.6, and phosphorus was also on the lower side, 1.8. The vitamin D levels were less than 4, and parathyroid hormone was elevated to 433. These were the this is the X-ray. Chest X-ray showing chest X-ray showing infiltration, and the X-ray of the lower limbs showing rapid changes. The uh, cupping, fraying, and splaying, and
Fine. How have you treated this child?
started him on antibiotic O2 support. Child was not maintaining, child was having persistent respiratory distress requiring intubation. So we have shifted him to PICU for further management.
Now, how is he?
Now he's still on O2 support by ventilator. He's still, the child is still requiring ventilator support.
Fever?
Fever spikes, no recent fever spikes in 24 hours.
Ventilating what looks like a emphysematous child is dangerous. So possibly findings are not right. Okay, have you seen any asthmatic being ventilated? If asthmatic needs ventilation, you need a tremendous expertise in ventilation. You will cause a pneumothorax, a pneumomediastinum, you will blow up the lung. So obviously there is something wrong, and most missing is the weight and length. Okay. Now if we don't know weight and length, then how would we know this is a resistant rickets? It cannot be nutritional rickets then. And then the whole story changes. And if it's the renal rickets, then this child has not been doing too well for a long time. Okay. So that itself would add on to the risk of infections. So I think we are quite messed up. See, what we want wanting to point out is history taking is so difficult and needs a skill and patience. And if you don't have that, then you are just depending on all kinds of investigations. And I think that's not very right. Okay, we get a wrong impression, what looked like on the history, whatever was given. But weight and length, how can you not mention in a pediatric patient? No, weight and length is absolutely this. Otherwise, we would not have known what's happening, right? And the other thing is that why is such a child without much infection is not coming under control with good oxygenation? Okay, now you say he's a little better. So he's quickly got out of it in spite of ventilation. So I wonder whether there was much emphysema at all. It would have been very difficult to ventilate such a child. So I think we are a little mixed up on that. What I'm trying to say is that not finding faults, but we get misled totally by our analysis. Okay. And you must have seen last 2 days what's happening. Vote chore, vote chore. Now the person who did that has come out saying that I have made a mistake. And what mistake? Instead of several columns, he mistook one column for the other, and he talked about nonsense, and the whole politics is discussing that. Can you imagine that? Okay. Now, we are exactly doing that. They are doing it at that national level. What a pity. Okay. So What I mean is that learn this, learn this. Okay, that a good history is a must. Next time onwards, we would be happy to have a child and a mother that we could ask her directly history also. Because we get a wrong impression that this is the way resistant rickets behaves. No, right?
Any questions or anything else? Anything from our online audience?
No, Rajesh, it has been a wonderful discussion, both cases. Thank you very much, Amdekar sir, Rajesh, and everyone, all those who presented.
Thank you. So next Thursday will be day 2 of Ganpati, like 1.5 day Visarjan.
Yeah,
So we will not have a class on next Thursday. So
okay,
we'll have it after that, right? Because
okay,
that 1.5 day would be quite everyone will be busy and all. So we'll not have it on that Thursday, right?
okay. Thank you, Rajesh.
Thank you.
Thank you, sir.
Rajesh, differential count was there.
Yeah, I was also asking, yeah, Palni, that 15,000 count, is there a differential? How many neutrophils, how many? Do you remember? $66 neutrophils.
Okay, Rajesh.
Okay,
It's not.
fine. Okay, thank you everyone. Thank
Thank
you.
you. Thank
Thank
you.
Bye.